At the outset, I would like to thank the organizing committee for having me here. It's an absolute pleasure, respected chairperson sirs and the esteemed audience. I am Ankit Balani. I am a consultant radiologist from Vijay Diagnostic Center, Hyderabad. As you would notice, my fellowships are primarily in neuroradiology, but I can proudly say maximum number of referrals that come on my name are MRI fistulograms, all thanks to the surgeon colleagues here. There are my disclosures. There has been fair usage of copyright works, and these are my crediting sources. Today's topic of discussion reminds me of a famous quote from the book Little Prince. It is only with the heart that one can see rightly. What is essential is invisible to the eye. For perianal disease, especially for perianal fistulas, this could be very well read as, it is only with MRI that one can see rightly. What is essential is no longer invisible to the eye. This was the seminal paper about the classification of perianal fistulas by Parks et al. You can see how good this paper was. Even after 5 decades, this is the most widely accepted classification system. They examined around 400 patients and came out with a classification system, briefly, which was talked by Dr. Praveen sir previously. So let us understand the pathophysiology first. What happens is there are anal glands which are primarily located in the intersphincteric space or into the internal sphincter but not in the external sphincter, draining via the crypts onto the anal canal, most likely in the location of the dentate line. Whenever there is an obstruction to this drainage, that results into a chronic perianal sepsis, and thus now the sepsis would come out onto the skin following the paths of varying resistance. The least path of resistance would be in the intersphincteric plane, resulting into the formation of an intersphincteric fistula, or else it could breach the external sphincter coming onto the skin, resulting into the formation of a transsphincteric fistula, or else it does not bother the sphincter complex, ascends up into the intersphincteric plane and then breaches between the deep part of the external sphincter and the levator ani muscle, resulting into formation of a suprasphincteric fistula, or else does not bother the sphincter complex at all, directly breaching the levator ani, resulting into formation of an extrasphincteric fistulous tract. Most surgeons believe that this is likely to be iatrogenic in nature because the perianal disease may not be that strong to breach the levator ani muscles, or else commonly associated with other associations like carcinoma, diverticular disease, or inflammatory bowel disease. Another classification system which we radiologists more commonly use is the St. James University Hospital classification system, given by Morris and Spencer et al. In the year 2000. It is just a simple extension of the Parks classification, wherein grade 1 is a simple intersphincteric fistula with no collections or ramifications. A grade 2 is an intersphincteric fistula with a collection or ramification limited to the intersphincteric plane. A grade 3 is a simple transsphincteric fistula with no ramification or collection. A grade 4 is a transsphincteric fistula with a collection or ramification within the ischianal fossa. And any translevator or supralevator disease becomes a grade 5 fistula. Another classification system that is used is the American Gastroenterological Association classification system, wherein they classify fistulas as either simple and complex. Simples are those which are either superficial, low intersphincteric, low transsphincteric with a single internal opening without any collections. Anything else is a complex, that is multiple openings, multiple high intersphincteric, high transsphincteric, those associated with strictures or rectovaginal fistula. So the first question, why do we need classifications? As we saw in a conventional fistulectomy or a fistulotomy, the surgeon would lay open the tract. So that would determine how much part of the external sphincter would be compromised if it's a transsphincteric fistula. We all know external sphincter is a striated muscle complex responsible for voluntary control, and thus would have implications on patients' incontinence. So these would be the 10 steps that I would be talking in detail, but before doing that, let us understand why is imaging important. So we all know examination under anesthesia is considered as a gold standard, but to a surgeon who's trying to palpate these two fistulous tracts, towards your left marked with red is a translevator fistula with a collection in the supralevator space, and towards your right marked in blue is the transsphincteric fistula with a collection reaching up to the roof of ischiorectal fossa. So you would see that a surgeon trying to palpate this would give us very similar palpatory feel, but the surgical outcomes of these two would be totally different depending on the length of the external sphincter that gets compromised. Therefore, what are the imaging options available? We have fistulographies. In the current era, please do not order fistulographies. Any fistulographies that comes to us, we convert it either to a transperineal ultrasound or to an MRI. Endoanal and transperineal ultrasound we'll be talking in the next lecture. CT fistulography, again no role, but in patients with contraindications to MRI, for example a cochlear implant, we can do with these CT fistulographies as well. The entire talk would be now focused on the MRI. So the first question that comes to mind, should we be Tesla specific? The answer is we are neither Tesla easy, not Tesla crazy. For perianal disease, both 1.5 Tesla as well as 3 Tesla does the job very nicely, and it could be on the user preference and the availability that we can opt for. Next, before reading the images, one I would say a boon that you as surgeons have is you have a patient in front of you, you have the skills to examine a patient and come to a conclusion before even the imaging is available to you. Therefore, please do that, look at the clinical history, do the digital examination, and then you could specifically focus on the areas of interest on the images. So the first step is how do you access the images and how do we understand the software. So first is let us get to a word that we radiologists commonly use, that's a DICOM format. DICOM format allows you to play with the images, you can window it, you can zoom it, you can do what not with the images. So the first essential thing is you should have an access to the DICOM images. This could be provided either in a study link, a CD or a QR code. This is how our report usually looks like. There's a QR code at the end and the link to the study. When you click that, you get the access to the entire data set. So what are the DICOM viewers available? There are multiple of them available, but one free software that is available is the Radiant viewer. I'll just spend 2 minutes making you accompanied to the software. So first thing is always do a split screen. Reading the MR is slightly difficult, so always look at 2 different planes together, you will get a better hold of it. Then you have simple options like scroll, windowing, pan, zoom, measure, etc. Now, before reading the images, let us understand how do we acquire it and what are the sequences that we acquire in. So first thing that we take a localizer, and on this we'll plan the scan. The first image that I take is a sagittal section on a T2 fat sat images. Why sagittal section? Because there is a constant pull by the puborectalis muscle, and thus the anal canal is always angulated anteriorly. Therefore, the MRI of fistulogram should be done along the plane of the anal canal and perpendicular to it. So the true axial for MRI fistulograms is different from that of an MRI pelvis. This would be in the plane of the anal canal. And just to give you an example, this patient came for a second opinion. I was not able to comprehend what is going on actually. So I looked at how the scan was done. This was done how a normal MRI pelvis should be done. If you see a scan being done like this, please send the patient back. This is not how a scan should be done at all. Next, let's start about understanding the basic sequences in the protocol. As surgeons, if you get acquainted to only 2 sequences, I'm pretty sure 99% of the times you would be able to understand what's going on. Towards your left is the T2 weighted images. How do you identify them as T2 weighted images? Look at the fluid in the urinary bladder, that's bright. Look at the fluid in the mesentery and the subcutaneous plane, that's bright. Both fluid, fat being bright, that's a T2 weighted non-fat saturated images. Next in the middle, you see that the fluid is still the bladder is bright, but the fat has all suppressed, that becomes dark. That's a T2 weighted fat saturated images called by multiple names, stir, spare, spare. Need not bother about it, but it is basically a T2 weighted fat saturated images. Towards your right is the T1 weighted images, wherein you see that the urinary bladder is dark, but the fat is bright. So fluid is suppressed, but the fat is bright, that is a T1 weighted images. Why do we need so many sequences? As you look at the first image, you are able to nicely make out the sphincter anatomy, the internal sphincter, the external sphincter. We'll come on to that in a while. In the middle, the fluid is shining bright. Any active disease would be a fluid containing structure, that is a perianal fistula. So that will shine bright on the stir weighted images. So first thing would be to find out the disease where it is. So you use stir images. To look at the anatomy, you look at the T2 weighted images. So what are the sequences? There are multiple sequences, of which I would want to highlight one specific sequence that I commonly use. This is a 3D weighted T2 weighted sequence. What happens in MRI is we usually have a 3 mm thick section, 3 mm gap, 3 mm thick section, 3 mm gap. So anything which is lesser than this would get missed. So smaller tracts will miss it. What we do here is we take a 3D weighted sequence without any intersection gap. So this provides you with the confidence of even detecting smaller tracts and get a better delineation of the fistulous tract. Let us now understand the imaging anatomy. We'll start with the schematic diagram and then come on to the imaging. So we have the dentate line which separates the stratified squamous epithelium of the anal canal with the columnar epithelium of the rectum. We as radiologists do not see that, but that's a clinical thing. Beyond this, this would be an internal sphincter. Then we have the striated group of muscles, that is the external sphincter. In between, we have the intersphincteric plane. This intersphincteric plane contains the longitudinal muscle of the rectum continuing down as the conjoined longitudinal tendon. Lateral to this, we have the ischianal fossa. We have the levator muscles which would separate the supralevator space from the infralevator space. Let us now look at this in a coronal T2 weighted non-fat saturated images. I would be marking it on one side so that you can still appreciate the anatomy on the other side. So we have slightly hyperintense internal sphincter that is marked with the orange here. Surrounding this, we have a more hypointense external sphincter because it is a striated group of muscle, continuing superiorly as a puborectalis muscle, and then onto the levator muscle attaching onto the walls of the pelvis. In between, we have the intersphincteric plane, and if you look carefully, there is a linear hypointensity there. This is the conjoined longitudinal muscle. Lateral to this, we have the ischianal and ischiorectal fossa, both being separated by the superior margin of the puborectalis muscle. Reviewing the anatomy again on the coronal and sagittal images, we have the internal sphincter which is slightly more bright, followed by the external sphincter, and you can very well see the three different subparts of the external sphincter, beautifully seen as subcutaneous, superficial and deep parts. Continuing in the space between as the intersphincteric plane, continuing superiorly as the puborectalis muscle, which has a constant pull resulting into a surgical and the anal canal and the rectum, and then we have the levator muscles joining it onto the pelvis. Reviewing the anatomy on an axial plane, you can see that the internal sphincter surrounded by the external sphincter, intersphincteric plane in between which is bright because it contains fat, and a linear hypointensity here is the longitudinal muscle. On this position, we give the o'clock position, which would be very comparable to the o'clock position when seeing the patient in the proctoscopy position. A higher up section, the similar anatomy, and as you move up higher, you can see the levator muscle going posteriorly, attaching onto the pelvic wall, and because it is above the level of the puborectalis muscle, we will be dealing with ischiorectal fossa. How do we interpret the perianal fistulas? So as I said, the first thing should be to localize the pathology on a T2 weighted fat saturated images. Anything that shines bright is most likely to be a perianal fistula, unless with a few exceptions that I'll be talking about. Once you have localized the fistula, start looking at the anatomy on a T2 non-fat saturated images. You will be able to locate whether it is in the intersphincteric plane or beyond. Look at the other sequences and try and comprehend the internal opening, the secondary branches, try classifying it and look for the other pathologies. So how do you try classify a perianal fistula? So the first thing to do is try looking whether there is a disease in the ischianal fossa or not. If there is no disease within the ischianal fossa, that means the disease is limited to the sphincteric complex, therefore it's an intersphincteric fistula. If there are no ramifications or collections, this becomes a grade 1 fistula. If there are associated ramifications, it becomes a grade 2 fistula. Suppose there is a disease process within the ischianal fossa, you have to look whether there is a breach in the levator plate or not. If there is no breach, that means it's a transsphincteric fistula. If there are no collections, that makes it as a simple transsphincteric fistula. If there are associated collections or ramifications, it becomes a grade 4 transsphincteric fistula. Suppose there is a breach in the levator plate or it goes supralevator, that makes it a grade 5 fistula. Again, why do we classify? Grade 1 and 2 would be simpler with a better surgical outcomes. Grade 3 to 5 would be complex with a more graver surgical outcomes. So as we discussed the classification systems as grade 1, that is a simple intersphincteric, grade 2, grade 3, 4 and 5. Another classification system that was given by Dr. Pankaj Garg et al. Is the perilevator hyphaenal fistulas. In this, he has beautifully talked about further subclassifying the intersphincteric plane into two, that is inner intersphincteric plane and the middle intersphincteric plane. So depending on that, we have 5 different types of perilevator fistulas, that is the supralevator, the suprasphincteric, high intrarectal, extrasphincteric, and the refill fistulas. And all these again beautifully seen on imaging. Talking about the most important role that I believe is confirming the presence of a perianal fistula, because I've seen many cases wherein it is not actually a perianal fistula being reported as one. So the hallmark of perianal fistula is presence of a disease within the intersphincteric plane. There are few other mimics, that is a pilonidal sinus. Veins being classified as perianal fistula. One second, there is some call coming to the PC. Yeah. Next we have hemorrhoids. Hemorrhoids, actually it's not our job to identify them, and we hardly identify them, but sometimes they are seen as lobulated T2 star hyperintense lesions. Identifying proctitis. Anal fissure, this is one thing which I see many commonly missed on imaging. The surgeon can see it, the patient complains of severe perianal pain, but it's seen as a blob of hyperintensity within the internal sphincter as an anal fissure. Ischial abscess not communicating with the perianal fistulas. And this case was quite interesting, wherein this was reported as an ischial abscess, but if you would see, it is going in multiple planes with not significant inflammation around. This was actually a low flow vascular malformation. This case I would want to highlight as being commonly reported as either ischial abscesses or intersphincteric abscesses, but it is a surgical nightmare. When you go in, you find a lot of mucoid discharge coming out, and then we have to either postpone the surgery or change the outcome of the surgery. In these cases, what we see is brilliant T2 star hyperintense contents between the intersphincteric plane with no much inflammation around. If we take the history also, the patient is not that symptomatic and complains of mucoid discharge. The clue to diagnosis is the heterogeneous enhancement of the disease process, and these cases are the mucinous adenocarcinomas. Many a times when I report that, the surgeons would ask for a PET CT scan. Unfortunately, these are not bright on PET CT as well. So they again think, no, this radiologist has reported it as wrong. And this is one my take-home message. One place where you would want to trust your radiologist is, please trust when I am saying it to be a mucinous adenocarcinoma. Next, what we do is look at the internal opening, the extensions, and the relationship to the levator plate. Internal opening, we give the o'clock position, that is according to the canal, and we give the distance from the anal verge. Here again, I would want to highlight, many people what they do is they keep a external marker at the level of the anal verge. But then depending on the extent of the gluteal fat, this will keep moving down. So I have seen reports saying that there is a infralevator fistula with internal opening 8 centimeters from the anal verge. That does not make sense, right? The anal verge itself is 5 centimeters. So the ideal way to do is looking from the distance from the caudalmost part of the subcutaneous part of the external sphincter. It is from here what we measure the distance from the anal verge. We talk about the extensions. I'll skip a few slides because we are running short of the time. We talk about the relationship to the levator delta. Now we talk about the sphincter integrity and the percentage of the sphincter involvement. So what we can tell on imaging is the exact level of the breach of the external sphincter, whether it is the superficial, subcutaneous, or the deep part, and depending on this we can act just 1 minute more. So, and depending on this we can give you an exact percentage of the sphincter involvement. More than 33% involvement points towards a complex disease and thus would have more grave outcomes. But the golden rule in radiology is not to stop at the obvious. Once you have diagnosed the perianal fistula, always look at the corners around. You may find associated inflammatory bowel disease. You may be able to look at and localize the stretons. You may look at other associated pathologies, as in this case, there was a prostatic cancer with rectal deposit as the primary cause. We may give you an idea about the activity of the fistulous tract, and sometimes the cases like these are actually a googly, wherein what I saw was the signal was not very much comparable to that of an ischial abscess. There was some heterogeneous signal with central hypointensity within. Usually abscesses should shine bright on diffusion imaging. In this case, there was only a peripheral restriction here. So I called up the surgeon. I said, ma'am, I think there is a gauze piece inside. So there is a gauzy bioma in a perianal fistula. She was like, have you seen it before? I said, no, but I strongly feel it is that. And here she operates it to find out a large gauze piece within the perineal abscess. The patient was actually doing doctor shopping. He was undergoing regular dressings, and then one day he decides not to go any further to that surgeon. 6 months later, he comes back with a large gauze piece inside. So this is how I usually report. I feel a picture speaks more than 1,000 words. For a surgeon to go through a large amount of medical jargon is not very practical, and in your busy schedules even more difficult. A 3D diagram would solve the picture. It gives you an exact pathway where the fistula is, how it's going, and may act as a surgical roadmap. I thank you all for your attention. I'll be happy to take questions if there are any.